Good evening, dear listeners, and welcome once again to another episode of HealthLink brought to you here every week by myself, Dr. Abubakar Jah, and my colleague Mariama. I think you should not panic. Usually Mariama is around, but she is indeed around, and she will come with me to conclude on the program at the end of the program. Today we have very distinguished guests who have left their busy schedules to come to this program today to share with you on a very important topic, which is cancer and breast cancer. As you know, this is Pink October, and since the beginning of this month we have been talking about breast cancer, and we're also taking the opportunity to talk about other forms of breast cancer. What I will do is I will not waste any time, but get my guests to introduce themselves. We're going to change the format of the program a little bit today. We're going to speak in English for the first 30 or so minutes, and then later Mariama and I will summarize all that we have talked about with our viewers. I think what I will do is I'll start from my right with ladies first, because we normally do ladies first. And Dr. Ramunjai, who many of you may know by now, but I will leave her to introduce herself, tell us what she's doing, which agency she's working for, and what her role on cancer is. Dr. Jai, welcome to the program.
Thank you, Dr. Jah, and thank you for inviting me. I'm honored to be here. As you said, my name is Dr. Ramunjai. I am a gastroenterologist and hepatologist. That means I'm a specialist in digestive diseases and liver disease. I currently work for the World Health Organization's International Agency for Research in Cancer, which is the specialized agency of the World Health Organization that deals with cancer, looking at the incidence of cancer and the occurrence of cancer, trying to understand the causes of cancer in order that we may prevent them. The agency does not deal much with treatments. This is done by clinicians and hospitals, but they are involved in collaborative research. So for me, as a gastroenterologist and hepatologist, what I have been doing really is looking into liver cancer. The liver cancer, you may know, is the commonest cancer that affects Gambian men. And Gambia is one of the countries with a high incidence of liver cancer. In fact, after China and Mongolia, Gambia is said to be the country with the third highest liver cancer incidence per 100,000 population. So it's quite a big problem. And there's a lot of research that's been done, and the vast majority of liver cancer in the Gambia is caused by hepatitis B virus, with aflatoxin, which is a toxin produced by a fungus that affects moldy groundnuts and peas and sorghum and maize. It produces, and that toxin actually acts, shall we say, as a co-carcinogen. And so, for example, to put it in simple English, if you have hepatitis B virus infection, your risk of developing liver cancer is 7 times the average, the general population. If you don't have hepatitis B infection, but you are exposed to high levels of aflatoxin contamination, and there are tests that can detect that, then you have a 3 times higher risk of developing liver cancer. But if you have both, then the risk is 59 times, 59-fold. So it's having both hepatitis B and being exposed to aflatoxin is a big cause of liver cancer. So the two programs I've been working on are the Gambia Hepatitis Intervention Study, which was to look at vaccinating children against hepatitis B and what effect that may have on preventing infection in the first place and also cancer in the long run. And the second project that I was doing is the so-called prevention of liver fibrosis and cancer in Africa, which was to look at those who were infected before the vaccine became available. And for these, we do what's called a screen and treat. So we screen for hepatitis B, we assess them, and if they meet certain criteria, we treat them. So basically, in a nutshell, I've been looking at the combined effects of vaccination against hepatitis B and treatment to see if with these twin strategies, we will be able to have an impact and even eventually eliminate viral hepatitis as a public health threat in the Gambia.
Well, thank you very much. I'm sure you cannot talk about all the things that you're doing. I know that because of the amount of work on liver cancer in the Gambia that you're doing, you're also giving the custodian of the cancer registry in the Gambia, and I think if we have time, we will go through that.
Sure.
A lot of work you're doing, and I am sure that the country stands to benefit a lot from that. But before we move on, I will move on to our next guest, who is Dr. Biteye, another very busy man who has agreed to come here and discuss this topic. Dr. Biteye, again, what you do and how your role in cancer comes in.
Like you said, I am Mustafa Biteye, and my training, I am an obstetrician and gynecologist. Until recently, I am now the acting director of health services. So in my previous role, which I still do, and I think I'll be having some time to go do clinical work a lot. I've been involved in the cancer care of patients, mainly in the screening and in the early diagnosis and treatment, mainly on cervical cancer and gynecological cancers at the Edward Francis Small Teaching Hospital. Now, we are looking at cancer from the bigger picture globally, from the policy level, to see how we're going to reduce these cancers in the whole country. Best is to prevent it, and prevention, either by vaccination, awareness campaigns, all that. We need to have policies on that. We also need to have policies on early detection, so that before they get bad. But all these things need to be universal. Doing pinpoint here might not have a lot of impact, but from the ministry point of view, for us to have impact, it has to be national and then organized, and so that we can have. And there are some strides which we'll discuss that are already been taken by the government to ensure that we do this.
And I'm sure there's a lot of collaboration, and now that you've taken that portfolio, you'll be working more closely with Dr. Njai as well in all the other endeavors that they're doing. And our third guest, again, somebody who works also on cancer in some ways, Mr. Modu Gassama. We will allow you again to introduce yourself, the agency you work for, and what your role in cancer is in the Gambia.
Thank you very much, Doctor. I also want to thank the listeners and those who are watching us. This is a very important question. My name is Modu Gassama. I work for the World Health Organization for the past 30 years. My portfolio is really like twofold. One is health promotion, and also non-communicable diseases. These are husband and wife. You cannot separate them. So for the past so many years, I've been involved at two levels. You have the upstream level and the downstream level. Upstream level is more to do with strategic issues like policies. I can tell you that because cancer, it belongs to a family. You cannot just look at one and then, because most of the cancers, they share similar risk factors, although they may be differ here and there. So as an organization, WHO's interest is to look at these policies first, help the countries to develop their policies, and that will give them the strategic direction. So I have been, involved with the Minister of Health. I've been involved in the first national non-communicable disease policy and strategy, and again, a very important risk factor which we are also as an organization is tobacco control. Tobacco, lung cancer. You cannot talk about lung cancer forgetting about tobacco use. So tobacco use has also been, for the past many years, we've been trying again at a strategic level to get the first national policy on tobacco control and an action plan. And then also there is a legislation which is also very important. I think Doctor will throw more light on that. But I've been involved in supporting the ministry develop the first comprehensive National Tobacco Control Act, which is now been, I think, is now been implemented. Thank God, the ministry has really given the green light, and also giving us the support, working closely with the WHO to get this thing a reality. So that is, in a nutshell, that is what I do at upstream level. But downstream level, again, because of health promotion, you need to sensitize, because people don't know. I mean, the evidence also must be generated. And like we also did, one example is the Global Youth Tobacco Control Survey. We did that in 2008 with the ministry, and also 2017. This is to gauge the level of smoking, among adults and also teenagers, adolescents. So we have interesting data. Maybe later in the program we can share that, because these are the risk factors of today, are the diseases of tomorrow. If you don't address them, the people with cancer, yes, they have their problems, but if you want to make an impact, you have to go population-wide, population-based interventions. And that's where you bring in health promotion, getting people sensitized, people aware of the risk factors and how they can manage those risk factors, modify them, or avoid them completely. So that has been my job for the years I have worked with WHO.
Yeah. Thank you very much for coming and joining us today. I think I will divert a little bit. Mr. Gassama has talked about smoking, and many people may just think that smoking has something to do only with lung cancer, but we know that in many cancers, one of the culprits that will be mentioned in terms of risk factor would be smoking. It's not only liver cancer. Absolutely. Things as far as bladder cancer, which is way down, would be something that, smoking. And I'm sure Dr. Biteye will agree that some of the gynecological cancers also, smoking will be mentioned as a risk factor. Any comments there?
Through the immunology pathway, people believe that it's also, because if you look at studies done, it has been implicated in, cervical cancer. Through the immunological pathway, sometimes it may be thought that it is also, maybe those who smoke tend to also probably be involved in risky behavior. Sometimes you can use that, but the immunological pathway is the main one we use in cervical cancer.
Dr. Jai?
Yeah, and obviously head and neck cancers and squamous
throat
cell
cancers.
And throat cancers. Definitely. Smoking is a well-known risk factor. So smoking is a risk factor for many cancers. And tobacco control is one of the main key things that a country can do to reduce the risk of cancer in the country.
And for the other risks also of the cardiac issues and so that could be a big burden, especially if the country is becoming a middle-income country. So the risk of mortality from it is very high, both from cancers and from...
It's very high. I mean, in this program, we've always talked about smoking and the risks of smoking in many different ways. I think if we start talking about that today, we will not talk about the main topic that has brought us here, but suffice it to say that it's a very serious thing, and it also interests us in cancer. One of the tools to fight cancer is availability of data, and time again, we lament the fact that we don't have much data here. What is the status and reliability of the data we have in the Gambia? Maybe starting with you again before we go to...
Yes, that's a very good question. The Gambia Hepatitis Intervention Study, when it started in 1986, it became very clear that if you are to follow these children long term and figure out whether vaccinating them prevents cancer, you have to have a cancer registry where all cancers diagnosed in the country are registered and entered. So the WHO, the IAC, WHO IAC actually set up this national cancer registry. Initially in 1986, it took some time to actually train staff, many of whom have a nursing or public health background, in tumor registry. So they're called tumor registration officers, or TROs. So they were trained in collecting specific data, which is demographic data, you know, date of birth, patient's name, you know, and so on, address and so on, and also tumor-related data. So if the tumor is actually diagnosed by a clinician, they have to take the diagnosis, and then the basis on which the diagnosis was made has to be entered. So, you know, any cancer. So sometimes it's histological diagnosis, which is very few, and I'll come back to that because that's one of the data quality indicators. Sometimes it's from clinical imaging, CT, you know, ultrasound, and so on. So the cancer registry shows, I mean, it has shown consistently, despite all the limitations, that liver cancer is the #1 cancer in men, followed by obviously prostate cancer, which you know a lot about, and lung cancer is coming up with the increase in smoking. Whereas in women, cervical cancer is the top cancer, and up until say 3 years ago, it was followed by liver cancer, and breast cancer was the third. But actually, over the past 3 years, breast cancer has overtaken liver cancer as the third cancer in women. When we evaluated the cancer, so after 20 years, the cancer registry was evaluated by an external evaluator. And the main issues were that there were not many elderly folks on the register. And it was like, why is that? Is it because the old people don't go to clinics? They don't get diagnosed? Do they just stay at home? And that led to some sort of hypothesis regarding the health-seeking behavior of patients, depending on age. But also, I think it was in part because if older people are less likely to travel long distances to go to centers where the diagnosis can be made. The other issue is that in the whole country, as you know, there is one pathology lab. And so lack of pathological diagnosis or pathological confirmation, histopathological confirmation, is an issue for us. But despite all that, be that as it may, actually the cancer registry, and the Gambia was until recently one of only 2 countries, Uganda being the other one, that had a population-based cancer registry. It gives us a pretty good estimate. It gives us an estimate of what the cancer burden is. We realized, certainly when I got here in 2011, 2012, I realized that actually we're missing a lot of patients because of the fact that we do not have oncology services in country. So many of our patients, the nearest place to go is Senegal. Others go further afield. So we spoke to our oncology colleagues in Senegal to say, can we get some of the data on Gambians coming there, and to try and get the data to be a bit more complete. But even so, we know that some people go further afield. They go to Europe and the States. So although we cannot say that the cancer registry gets every single cancer that's diagnosed, although the histological confirmation levels are relatively low because of lack of pathology. It nevertheless is a very good indicator of the cancer burden in the country, because we actually increase the number of tumor registration officers, so we have them in government facilities, and they do visit private facilities as well. So we have them in Banjul, at the Edward Francis Small Teaching Hospital, in MRC, in Bansang, in Farafenye, and they cover the regions, and they go to Basse and elsewhere and talk to doctors, nurses, go to the clinic, to the theaters, and pick up this. So yes, so we have data that I think we can start with to plan, because a cancer registry is not just to plan your services, but it's also important to evaluate the impact of whatever intervention you have. So if you start, say, a cervical cancer or liver cancer or viral hepatitis elimination program, you should be able, through the cancer registry, to see what is happening,
what it is doing,
what is happening with the cases. So data is important. I cannot overemphasize it, and I think that there is a lot we can do to improve the quality of the data that we collect, because really without that we're just groping in the dark.
Exactly.
Yeah.
No, I agree with you. I mean, there's a lot that can be done, and that's why I want to talk to Dr. Biteye about what do you think are the challenges? What is making it so difficult for us to get more accurate data? Obviously, what we are getting, getting something small is better than getting nothing. Okay. But I mean, obviously, there are some deficiencies. And what do you think the challenges are, and what can be done by government to make sure that this thing is important?
Because the data is very important in decision making, in guiding people to make decisions regarding strategies. And so what happened today, I'm just from a very important meeting where we are looking at this and methods that have been taken, or measures to reduce the inaccuracies and all. One of them is to ensure that there's periodic reporting, like quarterly. And today one of the meetings I attended was to look at the data that has been reported, how accurate it is, how many of these units are reporting as is expected, and what is the accuracy level when we compare. And I think what we are doing, it's helping. That is, you don't wait. You have registers. You have the way of collecting the information, collection tools. But if you wait till the end of the year to see the number of live births, some of the papers could get missing and all. But what is happening now is the institution report periodically, maybe every week or every month, to the centers, and then quarterly they all report nationally. So you don't allow it to accumulate, and then you miss your data. So some of the problems now, we are instituting some measures which we are doing piloting in different areas to use real-time data capture. You have tablets in some institutions, and then they enter the data straight away into the DHIS or some, in a platform that everyone can access in your office as a strategic maker or as a decision maker or as a policy maker. You can be in your office or even abroad and then have these are things that have been piloted. And the problems we are noticing with this is sometimes the verification system. Like, you have somebody has entered the data, but it needs to be verified, maybe double punching, triple punching, and these are some of the things that came out today that we really need to look at. But I mean, looking at where we are now, we are looking at electronic medical system, and this has been tried in some areas, like in the EPI. We've tried it, and with the help of Action 8 and all, my child project, and we are trying to expand this to other levels. Yeah, and we are also working we already have the DHIS already in the country. And so these are things that are going to make the work easier, data-wise. And I think that we are not perfect, and it's not yet general for the whole country, because it requires a lot of infrastructure, because the internet, the laptops, the data and all. This will help us to have data quickly. What we were having before is there's a lot of chance of missing data. Because the registers, you have the registers. After some time, it needs to be taken, and papers could get missing and all that. But this is real time, and there's tendency for people not to punch the registers, you know, they will be lazy because it's accumulated. But this is real time. It's better if it is gone nationwide.
Certainly better. We will have a minute or so before we go on break. But what I wanted to say was that one of the first things I learned when I started learning computers many years ago was garbage in, garbage out. And there is that tendency that in the small clinics or in the place where it is, people might punch in that something is a tumor when it is not a tumor, when there is no verification that it is a tumor, so that could mislead, or some people might not diagnose. And I know that definitely the rate of prostate cancer is underdiagnosed in the Gambia, and many men die with prostate cancer or of prostate cancer with nobody ever realizing that is so. And apart from the EMR, which is, I think, the way forward, which is going to improve things a lot, what is being done by the ministry to try to improve that, to make sure that in the points where these things are diagnosed, people who are well trained are there to input them and to encourage also clinicians, because some of us don't actually take part in it. I mean, you are in the clinic, you've diagnosed something, and you know, it is just there.
Yeah, I think we've walked outside the Gambia, and most of the time the final diagnosis of these diseases are usually after a post-mortem and all, and then you have a definitive diagnosis. In the Gambia, that's very difficult, and it's not that encouraged, I don't know, because of public reason and so societal issues. But like you said, yes, if you can't have that, another method better is to have somebody who is very skilled. That would be acceptable to, I mean, for the register. If you cannot have a pathological diagnosis, which usually is only done in Gambia, but going forward, I think it requires a lot of man resources, a lot of investment to be able to have it in another part of the country. I think in the long-term plans it will be there, but now we have to strengthen the one we have. And you know, we are working into that to ensure that the one we have in AFSTH is strengthened, and we have the human resources to run it. Because all these samples, any operation that you do, you must have a sample, and it should be taken for pathological examinations, and all that should come to Banjul. So it has to be strengthened. And then the other method is we use the lesser. I mean, if you cannot have pathological, then you use the most qualified person to give anecdotal, to give the evidence, to give what he thinks. Like if a urologist give a diagnosis of prostate cancer, it will be better than if a medical officer gives it. So in that way, we also trying to see how we can get the doctors also outside in the communities to serve wherever in the whole country, so that people get to benefit from them. So if you have these qualified people, the more qualified they are in the point of contact, the better in picking this diagnosis. And that's a long.
I think I'll come back to you. We'll have to go for a break now. Yes, and then when we come back, we will continue.
With so many things to do in a single day, it's important to have a network you can trust. When there's family and friends to connect with, and business calls to make, you need a network that is reliable and fast. Talk longer, browse faster, go farther, and roam wider. When your network is solid, the world is your oyster. QCell, your trusted network in the Gambia.
Welcome back, dear listeners. Just before going on the break, Dr. Biteye was explaining to us some of the challenges that we're facing with the cancer registry. I think it's a very important thing for us to talk about here because certainly it stands to improve from some of the uses of the cancer registry that Dr. Jai has mentioned. It stands to improve our status in treating cancer. Mr. Gassama, I know that one of your strong points is health promotion, and usually this you target to clinicians or the general population for the health promotion. Do you think going on a health promotion drive to clinicians, to doctors themselves and nurses, that they are aware that there is a health registry or a cancer registry available, and that people should do everything to make sure that whenever a cancer is diagnosed, it is captured? Do you think that can work, or are you making any plans towards that?
Very important indeed. In fact, I want to join my colleagues, to thank them really. They are struggling with the complexity of data. Data is in fact, it's a nightmare in most developing countries, unfortunately. So the Gambia is no exception. In fact, we are doing our best, and I'm sure we are proud of what has been happening. But again, going back to your question, is yes, every stakeholder, everybody is a stakeholder in this, especially those dealing with the clinicians, and of course people at the periphery. All the levels of all the cadres you can talk about dealing with human beings in the health system. That is why WHO is very much interested in helping countries to strengthen the health systems. And one way of doing that is to look at one important building block, which is the health management information system. I'm glad that Dr. Biteye has mentioned something about it, but the WHO has been, for the past years, working closely with the ministry to develop the capacity, to build the capacity to generate data locally. I mean, I can tell you that for the past few years, 2015, 2014, the ministry, for the first time, Minister of Health has developed what they call health service data indicators. It's very interesting. You see, although it may not be perfect, but you can see they are able to showcase the level of the problem, the magnitude of the problem in some of the conditions, and we are using that because health promotion cannot grow up in the dark. You need evidence also to educate, to inform the public. So that has really generated something important in diverse areas, non-communicable, the cancer, you name them. And the Health Promotion Directorate I think is using some of this data to educate the public. It can be done, yes, and it really involves a lot of capacity building, and of course we need to really strategize. We have to be strategic with it. And as I said at the beginning, that the ministry has to be lauded for bringing, I know it's not the time to discuss the lung cancer or tobacco use, but we are seeing now some very recent data on the number of people who are smoking, 13 to 15 years. This is very serious in this country. What we are seeing now, as I talk to you, nearly 10% of those children, age bracket, 13 to 15 years, are smoking. This is serious for a country like the Gambia. I mean, and for the adults, it's about 16% almost. They smoke. And we are now seeing a new era, which is like Caesar. About 8.4% of the children between 12 and 20 years are smoking Caesar. So these are all efforts of the Ministry of Health in collaboration with WHO and other partners to really come up with the data. I know it's a big challenge, but it needs a lot of capacity building, it needs a lot of resources, but because some donors don't want to go into evidence. Like that's why Dr. Ramu is saying it's very difficult. People don't, because they think it's time consuming. It needs a lot of resources. We don't want to go, and yet you cannot grow up in the dark. You need evidence. You need evidence. So it is a big challenge. It's a big challenge WHO is facing, and WHO has in the past been able to get countries really generate their own data, because WHO does not own the data. It's the countries. So what we do usually is we send these questionnaires, please help us complete this, and then we make an observatory. And there is an African health observatory where Gambia has, and not only Gambia, but all the countries in the African continent, they have their own country profile, their data. But again, if you go to somewhere, it's very sketchy. You hardly see something tangible. But you don't blame them, but also the systems are not that developed like in developed countries. So there is a lot of work on it, and I'm sure countries, WHO always say the countries take the ownership, the leadership, but WHO can only supplement, because data belongs to the country. It's a very sensitive area. You cannot go and parachute in the Gambia and then this is my data. So it's the countries. And our business as an organization is to strengthen the capacity of the ministries of health to generate their local data and to be able to analyze and utilize those data so that they can make informed decisions about it. So this is a bit challenging.
It is.
And I'm sure with time we'll
Well, you
get
see, cancer is a very strong enemy.
Yeah.
And therefore you need to collaborate with many people to get it done. And that's, we can see the collaboration that is going on between IAC, WHO, the Ministry of Health. I just want to go into one small topic, maybe 1 minute, Dr. Biteye. We've been talking about all the things we want to cover today, but I'm sure time is fast running. But quickly, increasingly, the private sector is having to deal with cancer in the Gambia. Is there any plans to work with them to see that some of the cancer that are going in those areas are also captured into the registry?
I think, you know, for the ministry, the private sector is a good partner, and we look at the country holistically. So all the policies, this is some of the things, the reports I'm getting. All private facilities are supposed to collaborate with the government closely, because we are working for the same people.
Sure.
And the ministry is having the view, the whole picture, is seeing the whole picture for the whole country. And so we need to have the data from all the private facilities. And one of the challenges we are having, and the reports I'm having, is that sometimes, for example, we are doing training for focal persons, and some of the private facilities were asked to send focal persons so that they can be reporting on certain diseases that we want to be reported for the ministry. And the facilities responded, few of them responded that they don't have persons to send. And we've been having problems in some of the facilities to be sending their report. And because of that, going forward, in next year, we are planning to start the registration, the licensing of private facilities. And this is a condition we are going to put there. If you don't do it, then we will have to cease your license or not provide you. So we really expect cooperation from all the private. Don't see them and us. Yeah. We are one, and we are serving the same people. So going forward, we will not accept that.
Great. Maybe a little time again. Dr. Ramunjai has talked about one of the cancers. I mean, we have in males, the main cancer is liver cancer. In females, the main cancer is cervical cancer. And both of these are caused by viruses and preventable. What are the steps that are being taken to try to prevent? I know that you've mentioned some of those in liver cancer. We'll give you some time to just elaborate on that, and then that will be a chance for Dr. Biteye, because he's been wanting to talk about cervical cancer, to talk a little bit about cervical cancer and what are the things that are being done, which are very exciting. Dr. Ramu first.
Yeah. Yeah, for liver cancer, as I said, one of the first things when it was realized that this was a vaccine preventable disease was to first of all do a test of the vaccine, of the hepatitis B vaccine. And this happened in the Gambia. The Gambia was probably the first country in Africa to have this vaccine trialed here between 1986 and 1990. And at the time, the vaccine was not available to anybody. So through what was called a stepwise design, it was done in such a way that half of the children that were born in that 4-year period received the hepatitis B vaccine plus the EPI vaccine, and the other half just received the EPI vaccine. And it was shown quite clearly the vaccine was effective in preventing infection, in preventing chronic carriage in children. So the chronic carriage in children pre-vaccination went from 12% to less than 1%. And so from 1990 it was decided that this vaccine should be introduced to the EPI for all children. And that's how through this Gambia hepatitis intervention study that hepatitis B vaccine was introduced into this country. Obviously, at the time, the vaccine was very expensive, and the government needed support, the ministry needed support for another 5 years, and after which the cost became so low that now the government can afford to pay for hepatitis B vaccine 100%. But we noticed that despite vaccinating since 1990, the liver cancer rates are not going down. In fact, they're predicted to go up. And why is that? Because there were some people who were already infected before the vaccine became available. And once you are infected, the vaccine is useless. The vaccine is to prevent infection. And that's why we went into this second phase of trying to see if by an additional strategy of screening people for hepatitis B surface antigen using a rapid test, we could do that. We used two strategies in the facility in Edward Francis Small Teaching Hospital and in communities in the West Coast region. So we screened over 13,000 people, and we found that 10% of them were positive. And out of those, another nearly 10% actually had liver damage they didn't know about. Okay. So we started them on treatment for hepatitis B with oral tenofovir, which is a simple pill that you take once a day. And really, we were able to show that, first of all, within 1 year, the virus, people with very high viral loads, in the millions, would be negative for virus after 1 year of treatment. And we're still looking at the data, but what I can tell you is that if you catch people early enough, you can actually reverse the liver damage. But if they have established cirrhosis, then unfortunately you can keep them stable for a long time, but their risk of liver cancer is still there because the damage is so severe. So the lesson that we have learned from these two research projects, which some of them are still ongoing, is that vaccinate all the newborns, vaccinate them at birth within 24 hours. This is one of the key methods of preventing maternal to child transmission of hepatitis B. Obviously, there are new guidelines that are going to come up which will recommend treatment of pregnant women who have high viral loads to stop transmission to the
baby, just like it's done for HIV.
Just like, yes. So, so basically, liver cancer is preventable cancer if you prevent infection with hepatitis B, if you prevent contamination with aflatoxin, if you actually screen the population and treat them before excessive liver damage occurs.
So just quickly, the treatment is available. Is it the tenofovir? Is it available now for treatment of people? If somebody comes to me, for instance, with hepatitis B and say, I want to be treated.
Not yet, but soon it will be, because we're working on that. So at the moment, it is available for those who are registered with our trial. And what we have done, working with the ministry, is to prepare a national viral hepatitis strategic plan and policies aimed at eliminating this virus as a public health threat, because the Gambia is one of 194 countries in the world that signed this pledge to eliminate. And to do that, we're going to have to screen the whole country and offer treatment to those who need treatment. So part of that, so this is part of the strategic plan, the availability and access to treatment with tenofovir. Now, you'll be happy to know that when I started out, tenofovir was extremely expensive. I mean, I used it to treat patients in the UK, and it was something about like £1,000 per patient per year. And now it's gone down. The cheapest you can get it for generic tenofovir is about £30 per patient per year.
Which is very cheap, yeah.
And you know, and for countries like ours, I think we can even get it for a lower price. So that's what we're working on right now as we speak, on getting access to tenofovir for the rest of the country as a prerequisite to actually doing the national screening program.
Well, we set off to talk about breast cancer. The time is almost gone,
I know.
and we have not even touched breast cancer.
I know.
and and we must allow the director to talk about cervical cancer. So what I will do is I'll give you as little time as you can use to give us an overview about what is happening on cervical cancer in your part, and then we can just mention a little bit about breast cancer before we close. But we must sit down again. I think this is a very wonderful panel to talk about cancer, and I think we must organize again to sit down and talk more, because people need to know about this. People will be happy to hear more about this this problem, because they are slowly beginning to understand what cancer is, and I think we do need to talk about it. So I will definitely invite you again to talk about it. But Dr. Biteye.
No, thank you. Yeah, I will not take much of your time, because it's very important. Most of the cancers, cervical cancers we have, like Dr. Njai alluded to earlier, they come very late. 70% come very late, and we end up referring them to Dakar, and they will go there. Nothing would be done for them. Maybe at most palliative radiotherapy just to stop the bleeding and all. And they come back because it's very advanced.
It's late, yeah.
Now, Gambia, we are lucky to have the vaccine, you know, and it's going to be nationwide, you know, from, I think, early next year. We've already started in Brikama, but we want to roll it out to the whole country. And I'm just saying that this is a big opportunity for the country, and people should capitalize on it, so utilize it. But what we had from the demonstration, sometimes you see, especially maybe from the private schools and all, maybe they don't understand very well. And because of that, you know, I received a lot of calls asking whether my child should be vaccinated or not. And this is between 9 and 13 years. Those in grade 3, we are going to vaccinate. Maybe in certain places it will be from grade 3 to grade 7, because we are trying to catch up. But the whole country should know that this is an opportunity, and this is going to prevent a lot of children, when they grow older, they will not have the cancer. And to present late, be going to Dakar, going through all these problems. So let's embrace it.
Great, and I think this is really very important, and maybe I'll just give a minute to Mr. Gassama to talk about the health promotion in that situation, because people need to know. I mean, a father would say, no, I don't want my child to get injected. Why are you giving an injection to my child? Why should they?
Yeah, exactly. I don't blame any father if you don't understand the issue. I don't blame them. But once, I'm sure health promotion has that advantage in trying to really understand, because it's also behavioral change is a very complex issue. It cannot be done overnight. So we need to really get to the bottom of the matter. Why are they thinking that? You see, we engage, and of course we design our interventions. And most of the time, unfortunately, 90% of our time is just, we think we just give the information and that's it. That will never change. But we need to really go a step further to engage people, let them listen to them, dialogue, and see why is this. Once they are convinced, that's the way to go. So there is no one size fits all. We need to really have complementary approaches that, you know, as health promotion experts believe in, so that you can make a change. Only one approach is not
will not work. Well, I think this is a war against cancer. These are the generals in the war, and I think definitely we will need to have you again on this forum. But I just want you to give your last words so that we can invite Mariama to come in, and then we will just give a brief summary. We don't even have time. I think we have about 3 minutes to give a brief summary, and promise our listeners that we will relay this in the local languages, probably in the next program that we have. But yeah, starting again, I think this time I'm starting from the men, then go to the lady. We go reverse. Last word, sir.
My last word is the risk factors. You cannot talk about cancer without talking about the risk factors. Those who are showing the disease at a late stage, we unfortunately, something can be done, but again, we don't have to wait. So prevention is very key. Let people know about the risk factors, and then you know, that's what WHO is doing. Make sure that people know the risk factors, and you design your health promotion interventions to really address that. So I will
Dr. Biteye, last
so
words.
maybe I'll just encourage all, not women only, all men and women, to ensure that, especially we are in the breast month, for the women to ensure that, you know, although men can also have breast cancer, but to ensure that they do the screening periodically, self-breast examination. And then, you know, if they see anything, let them not ignore it. if they see that their breast is changing or all that?
Well, we have a breast screening program which is coming up on Friday and Saturday, 1st and 2nd of November. We're going to talk about this, Mariama and I, at the Arch, where we're going to have some Senegalese colleague coming in. We're going to have a mammogram coming, and we hope to screen more than 300 people during this period. So people should come out for that screening. Dr. Jai.
Yeah, I mean, cancer is preventable. Cancer is curable if it is caught early. As they say, you know, prevention is better than cure. Early detection saves lives. Yeah. So that's you know, cancer is an increasing problem, but we can deal with it, and we should deal with it, and we can only do so in a collaborative way.
Thank you very much to my guests, and I promise you that we are going to try to get them out here again. They are very busy, so that we can talk more about breast cancer. It was a very great pleasure talking to you all, and we hope to see you again and talk more about this deadly disease. Thank you so much. We'll take a break, and then Mariama will come back again, and we can. Thank you.
With so many things to do in a single day, it's important to have a network you can trust. When there's family and friends to connect with and business calls to make, you need a network that is reliable and fast. Talk longer, browse faster, go farther, and roam wider. When your network is solid, the world is your oyster. QCell, your trusted network in the Gambia.
mbokk yi ñu ngi leen a nuyuwaate fii nii ci QTV ci seen programme Health Link bi nga xam ne man docteur Aboubacar Dia ak Mariama Sané ñoo leen ko di indil fii nii semaine bu nekk weer bi nag ñu doon waxtaanee breast cancer tey comme noonu leen ko gisee nii ñu ngi jégalu nag ne programme bi yëpp lu ci ëpp yëpp def nañ ko ci anglais parce que dafa amoon lu bari luñ bëggoon a waxtaanee waaye dinañ leen dig ne beneen yoon suñ ñëwee dinañ gën a dugga si suñ gan yi lan lañ waxtaanee suñ gan yi nag mooy ñett ñu ngay doon dégg ñuy doon waxtaan jigéen bi mooy docteur Ramou Ndiaye nga xam ne moom mu ngi liggéey ak mbootaay mi yore wér-gu-yaram ci àdduna si yëpp ci biir mbootaay boobu noonu mu ngi liggéey ci mbootaay bi nga xam ne mu ngi ci biir mbootaay boobu nga xam ne ñoom ci mbiri cancer rek lañ dee liggéey ñoom ñoo yore mbiri cancer yëpp ci àdduna bi moom nag yàgg na di liggéey ci cancer bi nga xam ne mooy dal rees bi mu nekk cancer bi nga xam ne wax nañu ne Gambia ci àdduna ci yëpp mooy ñetteel wala ñeneenteeli dëkk boo xam ne ñoo gën a bërile cancer bii nii foog naa ne si suñ waxtaan yi mus nañ ko fee waxtaanee ba ko wax nit yi mu nekk lu garaaw a garaaw waaye mu nekk loo xam ne tam def nañ si ay gëstu yu bëri yoo xam ne Gambia la jógee fii nii te ñu ngi see jël ay jéego yu bëree bëri so moom waxtaan na ci yooyu noonu ak liggéey yoo xam ne ñu ngi koo def wane ne liver cancer bii nii lu ñoo mun a fànqa la parce que lu ko indi benn jàngoro la boo xam ne soo fànqee jàngoro bi di nga ko mun a fànqa te léegi nii am nañ vaccination bi nga xam ne xale yi lañ ko dee jox pour ñu mun a fànqa jàngoro bi soo demee tam ba am feebar bi gis nañ ne am na faj boo xam ne soo ko fajoo rek faj bi dina la génneel pour nga mun a am cancer te faj boobu noonu léegi tey mu am ci Gambia te mu ngi gën a yomba léegi nii waxta tamit ci mbiri gerte yeeg suuna yeeg yooyu nga xam ne dafa saabu te def day indi liver cancer lii nii yëpp waxtaanee na ko suñ beneen gan bi di docteur Biteye moom moo yore mbiri wérgu yaram bi moo nekk ci ron ministre bi yore mbiri wérgu yaram bi dëkk bi yëpp mooy yëpp lopitaan bu nekk ci biir dëkk bi moom moo ko war a saytu moom tam waxtaan na ak askan bi wax ñu lan mooy jéego yi nga xam ne nguur gi mu ngi koo jël pour wàññi cancer ci dëkk bi wax nañu tam ci mbiri feebar bi nga xam ne jurukaay jigéen yi cancer bi foofu la dee nekk wax nañu yan jéego la ñoo jël parce que moom ci loolu la doon liggéey wax nañu tamit ne léegi nii am nañ beneen vaccine bu ees boo xam ne ñu ngi ko bugg a commencé boobu nag doo ko jox neene yi boobu noonu xale yu nekk école nga koy jox te léegi ñu ngi bugg a dëkk bi yëpp am ko ba nga xam ne suñ doom yii nii suñ doom yu jigéen yi nga xam ne ay xale lañ léegi suñ demee ba mag duñ am cancer bi nga xam ne mooy dal jurukaay yi ñuy ñaax nag nit yi yëpp ñu make sure ne seen doom yi dem école dinañ leen di ñàkk boobu noonu ba nga xam ne duñ am cancer boobu noonu suñ beneen gan bi di Mr Momodou Gassama moom mu ngi liggéey ak WHO moom moo yore mbiri waxtaan ak nit yi ak askan bi ci mbiri feebar yi nga xam ne mooy dal nit yi nga xam ne nekkul feebar yi wàlle comme cancer ak yeneen feebar yi moom tamit wax nañu jéego yi nga xam ne WHO mu ngi koo jël moom nag am na dugg na ci loo xam ne lu am solo la man lu ma dee bëgg a di waxtaanee mooy mbiri tux cigarette ba wax na fii ne tux cigarette bokk na si li nga xam ne cancer yu bëri am na ci loxo foog naa ne si gàttal parce que amuñ waxtu loolu lañ waxtaanee tey di jéggalu nag ne lii nii yëpp mënuñ ko na wax ci olof wax ko ci angale parce que luñ bëggoon a waxtaanee yëpp sax mënuñ ko woon a waxtaanee waaye ndànka dinañ gën a tee dugg ci topic yi nii di gërëm nag suñ gan yi nga xam ne képp ci ñoom liggéey lu mu am si liggéey doy na ko waaye jël na time boobu noonu ñëw fii nii waxtaan ak ñun Mariama foog naa ne lii lañ waxtaanee woon tey.
Maringal assalamu alaikum mbal kontonna alla la moy ni mala comme ngali aja nyamin dorong bi mang be yam fu dani la folo jani be kufala comme mang programme commencé nin na kangol min nan dalita kake bari nga luntangol le soto jang bi adu nyin luntangol kumaya batale adu ngi ning kacha min nata jang ngaji ko be banko na falale bari hani kabi dorong mi fo fen kacha ta jan dorong ba katal le nga suti andi pour mol sa faham demanding ning atara bota je dorong programme ko tengol minil kana ba katal le nga nyin kacha na tinang pour mol sa faham min be kachata jambi coming aliya je dorom be nga luntan sabale soto do nyimu docteur Munjay leti wol dol boy du kola jata kende ya bumbale to minili alon ko tolle marata kansala mi ya lon ko dunia be kansa e tolle marata wala biyata la kacha mu mintu dum wala komi tolbe do ko min ke kan be kiskisirol mini ke kan adungi be silol mini ke kan pour ka dunia tanka kansal minili ya lon ko coming kansa mi ya lon ka liver male o kansal ni ya itandi ko mukurane te mi ya lon ka buka mo fa ning atare wulita ye borol soto nyanda ka soto nyamin atila kacha nyati linta walla adu hani kabi fanan ay silol le fo coming aya fo ko doron coming nyinti yol minili ya lon ko kam ko tiya safunol anin nying domor fengol nin kaminil domo mi ya lon ko ning atara angi domo dorong wali keta coming keta nyinti safuno ise ku be kala kulati mi ya lon ko ise nyatili no coming ka liver cancer soto baramu kurane mi ya lon ka buka mofa adungi tolbe silol tamakane pour ka borol fintinde mi ya lon ko ise mol mako ino le pour ka nyin jankaro kele pour inyaka na tiling cancer la mi ya lon ka liver male nga do fana je docteur Biteye wobe do ko la man sakundale to adi tolla do ko fana muminti pour ka mol mako ifana be kiskisirol ke kam man sakunda se silol min tamandino pour ka silol landi isaje nyin kansa mi ya lonka be faring dunia ko no fanan isa tala banko kan ako hani kabi doron ya nyin kansa mi ya lonka ka wulu nyango muta man sakunta ba kata kan pour ka borol fintini mi ya lonko iba dila dindingol la kabo minil be karambungo to buku sabakata fo buku woro wala iba kata la pour ka dindingol pengu baydi ta dina no dina no la bari ba kata la dindingol minil ya lonko se pengu no ka boro di la ke pengu isaje ning atare ke bayate itol fanante nyin kansa sotala mi alon ka wulu nyangol ma oto be do ku balla nyim banko kan adung fanan ibe nyin kiskisirol fanan ke kanne pour ka silol fanan yitandi pour ka banko ma ko ke tanka warka kansa lasiando tala banko kan luntan sabanjamu dok Mr Momodo Gasamalati ate fanan do ko be abe WHO le wala fanan marata coming nyin dunya fanan ate jata kende abun no min yal ko fanan marata dunya jata kende akarola akoy tol fanan be kiskisirol ke kanne adung yebe silol minita kam pour ka banko fanan ma ko hani kabi do ate nyin kansa lom itol be muso jarole to mi alon ko be ila do ko nyatlinta kansa ke lol la pour ka tala banko kan adung ate fanan yafa ko itol ka silol minita adung ala kacha nyatlinta fanan ko min cigarette sabo nga fo nyami docteur wato wati do aka tu cigarette sabo folale aka tinyaro min ka hadama dingo balo kono adung aka nyatlindi kansa lale ate fanan mu kulete mi alon ko kansa jamal mi yaji be do ibuka cigarette o bondinoje hani wulu nyang kansa dolbi je fanan fay cigarette o da ke je aya fole do ko mi be silol minita kan pour ka banko fanan ma koy ka wo fanan tala adunga ya fako dindingol minili alon ko sain ka bo sanjit tan saba kata sanjit tan lulu wol ngajel ko wo dindingol cigarette sabo siati kono bakel oto tol fanan hani ka bi do be silol le ta kan kanyin kele woto wato man si ambe ka cha sen.
Thank you. I think we've run totally out of time. I just want to remind our listeners mangi buga fatel rek time bi jeexna tak ne aljuma bi ni ak samedi bi ni si aaj bi képp koo xam ne jigéen la soo demee foofu noonu dinañ la seetal sa weeni seet ndax yaa ngi am cancer ñu wax loolu noonu si Mandinka ñu tàggatoo ñu jeexal programme bi parce que jeex na tak
mbaringol mba falale commune na kachata milanga foko nung November kari atili follow na atili full njango jula at 22nd banjun ibe mol kumandi la je nortable betar la sidi jele pour ka mol jibe ke sunjol jibe fo atare cancer sotale otombe mol fala pour mobe e finti yakata yetaje ni ngatra musuka fuke yetaje ye fangol makoy mba falale ala baraka follow kun kote mbayri watu bantale tak tak
jërëgeen jëf ci déglu bi di leen dig ba beneen yoon insha Allah.